I have no relevant disclosures. So what does the future in biologics hold? In an attempt to not wander off into wild speculation, I decided to consult an expert, the Magic 8 Ball. And what I got was, who knows? So it wasn't particularly helpful. What we're going to do today is basically review the highlights of the basic and translational literature, the NIH clinical trials database, and relevant internet sites for concepts and items that suggest innovative use as a future spine biological or a novel delivery for biologicals. Most of the focus to date for the biologicals has either been to reverse DDD or to augment fusion success. As far as reversing disc degeneration, most of the studies have used direct discal delivery of either small molecules or stem cells or gene therapies, including genetically modified stem cells or adenoviral vectors, et cetera. In the posterolateral gutter, in the delivery of various different agents to the disc space, what they find is that most of the TGF-beta family members, as well ADSOX9, will help to increase disc health, but I haven't seen any of these come to market yet or even trials yet other than the GDF5, which we'll get to in a few minutes. Other early data for agents that would potentially help with DDD, including IL-1 receptor antagonist, which helped to decrease matrix degeneration and also had an anabolic effect. Lactoferricin, which inhibited IL-1 beta signaling and helped with decreasing MMP and matrix metalloprotease induction, restoring proteoglycan production, and tripotylide, which again inhibited the IL-1 beta signaling and helped with disc macromolecule production. Another is Sonic Hedgehog, as with Dr. Dahia, one of our basic scientists here at HSS, and she's also published with activation of Sonic Hedgehog through Wnt. So again, Wnt overexpression or turning on Wnt signaling in the disc space may be something that will help to reverse disc degeneration. Other more mature agents include, as I was saying before, the GDF5 or BMP14, which has undergone phase 2 trials and is considered by the American Society for Interventional Pain Practitioners as a potential for clinical, broad space clinical use for disc degeneration. Less developed is the platelet-rich plasma, which Dr. Lutz has popularized here at HSS, as well use of mesenchymal stem cells, these bone marrow-derived agents, which may help to repopulate the discs. Each of these are considered level 3 evidence by the AI, or the American Pain Medicine Society. Magic 8 Ball, like, how am I doing? Don't panic just yet. As regards to fusion, any of the molecules that you see in this schema are capable of driving bone production and could potentially be clinically relevant factors. Augmentive agents, including VEGF or any of the others, are basically useful for osteoinduction, and even the inflammatory cytokines TNF, IL-1, IL-1 beta are helpful in pushing uncommitted cells into a bone lineage. So oddly, for as much as they usually get wrapped as being anti-bone, they're pro-bone in at least part of the differentiation cycle. Some of the agents have been used in posterolateral delivery either as adenoviral vector or in purified form, and have been successful in causing the posterior elements of the spine to directly fuse or to ossify the posterior erector spinae muscles to cause a relative fusion. Again, none of this has been converted into a clinical application in the past 15 years, and I don't think this is something that we need to worry too much about seeing. We also had work here doing the same using genetically modified cells delivered to the disc spaces, and what we were able to show is that you don't make bone in the disc, because again, those BMPs in the disc make the disc healthier, but you can actually make bone anterior to the disc and cause fusion events to happen. More bone. So again, direct delivery to the intended fusion site in the operating room is where most of these agents are going to be used. Currently, the BMP2 and 7 infused and OP1 are in use. There's question about the potential market for BMP6 and BMP9, much more powerful osteoinductive agents, but to date, I haven't seen anything in the clinical trials databases. PDGF beta is already used for foot and ankle fusions, and I would wonder if that's going to be something that we'll start to see drifting into the spinal ORs, but to date, I haven't seen it. VEGF, I talked about before, it's an additive agent. When co-delivered, VEGF and BMP can increase the osteoinductive character of BMP by about 5-fold. I haven't seen anything yet in the clinical trials database about that. PDGF we just touched on. Again, FGF, IGF, or any of these could also end up in a product where multiple factors are mixed in the OR and then directly delivered. I'll talk on Wnt specifically. So Wnt in its canonical signaling pathway interacts with the LRP receptor as well frizzled and causes intracellular signaling that ultimately causes beta-catenin to localize to the nucleus, which then causes all sorts of other bone-directed signaling. We don't need to get into that. The Wnt pathway itself is inhibited by two factors that sequester Wnt, including WIF1 and SRP, and two other factors, DKK and sclerostin, which bind to and inactivate the LRP receptor. Again, all four of these would be decreasing Wnt signaling. And you might wonder, could we use these to our advantage? Oddly enough, this has already been on the market for sclerostin by Amgen as well Novartis, where by inhibiting the Wnt inhibitor, you can turn the Wnt signaling back on. It's very effective for use in osteoporosis management and osteogenesis imperfecta. Again, to date, not used in any bone applications that I was able to find. A DKK inhibitor by Novartis is in phase 2 trials and is being used for the bone destruction associated with multiple myeloma. But again, I would kind of wonder if this is something that might be used more broadly in orthopedics and spine fusion. With one in inhibition and releasing the Wnt ligand, it seems to correlate with osteogenic sarcoma activation. So there's a concern about going too crazy into turning the WIF1 downregulation off. But again, I'd wonder. And SFRP, there's a small molecule that's been described by Millipore, but that hasn't gotten out of the petri dish yet. But again, keep your TV tuned. PTH analogs, here are known to decrease all of those Wnt inhibitors, the WIF1, the DKK, and the SOST. For Teo, this is teriparatide as well. Timolose, which is the abaloparatide, are currently on the market and FDA approved for osteoporosis. There's been some off-label use of Forteo to try to augment spine fusions. I would say it's a lot more successful in the rat and rabbit trials that have been published and probably less successful in the human so far, but something that would still be something to keep an eye on. And lastly, the rank OPG system. There is Prolia, which is an anti-rank ligand, which has been on the market for osteoporosis. To date, I haven't seen it used for the augmentation of spine fusion, but I kind of wonder if maybe we're going to start to see some of that. Back to our magic 8 ball. How am I doing? Have we completely lost everybody? It is decidedly so. For the innovation that you might see in delivery, currently we're directly delivering things in the operating room here, bone graft, but you could imagine that being just the BMP or any of the other agents that we were talking about before. Getting an infusion, again, for the Prolia or some of the other agents that I was talking about, subcutaneous injections such as the PTH, and IR guided here with the IR guidance to the disc space. But you could just as imagine seeing the agent being delivered to the posterolateral gutters or another place where you want the induced bone to form. What could the future hold? Oral. May it be possible that the PTH from Entera delivered orally make it through the FDA trials and be something that would then pave the way for other agents to be delivered similarly? I would certainly hope so. That would be pretty easy for us. How about transdermal, just putting on your Nicoderm patch, but having your PTH or other agent going through that versus, I was just trying to wildly wonder, but a vaporizer, would that be something that would be useful? Because what we'd like to do is to try to avoid putting zippers in people. Try to do this with a more sane approach. So how did I do? Magic 8 ball.